Hi everyone. Just want to make sure that you guys can see me and hear me. Just if you can let me know in the chat. Good morning or good afternoon, depending on where you guys are at. Do you guys have access to the chat? Hello, Omar. Hello, Susie. It's nice to meet you, everyone. Let me just introduce myself. My name is Dr. Kotouf Mubarak. I'm one of the tutors here at thematchguy. I passed my step 1 exam and I scored 263 on my step 2 exam. I'll be taking you guys today throughout musculoskeletal systems, specifically like parts of rheumatology. So like rheumatology is a wide topic, right? So we're going to be focusing like mainly on arthritis and we'll like dig in through a bunch of topics, okay, for today's session. Before we get started, hi everyone. Hi Sheila. Hi Helena. Okay, it's nice to see like we have wide varieties of people. It's nice to see that. Okay, before we get started, I just want to highlight something. If you haven't already like downloaded our high-yield files, please make sure you do. These are like really good when you're starting your prep in order to guide you throughout what's important, what's like more high yield than other things that are like less important. As well as if you're like at the end of your prep as a recap material, these are extremely useful. So please make sure to do that. And they're completely free. You can see the links on the chat as well. And if you're someone who like enjoys a one-on-one approach, also make sure to check out our tutoring. We have a bunch of tutors available. You can try like a trial session before you commit to everything. And if you like a fast-paced approach with courses, something that's quite similar to what we're going to be doing today, you can also check out our courses for step 1 and step 2 and step 3 as well. So make sure to check all of these resources and hopefully like good luck to everyone before we start in your journeys for USMLE in general. Let's dig in. Please try and be as interactive as possible. You can ask me questions in the chat. You can also answer like try and answer as much as possible. These sessions, the most like important part of them is the live interactions, right? We want you to like apply this knowledge extremely well, and we want you to apply this knowledge and like if you apply it in this session, you're gonna be able to apply it in whatever session, okay? So let's dig in. Like I said, we're gonna be focusing mainly on like arthritis. So let's start by comparing rheumatoid arthritis versus osteoarthritis. Okay? Can anyone tell me like age-wise, what kind of age would we like assume for someone who has osteoarthritis? What's like the age that we would see for someone older? Very good, Carolina. Yes. So someone who's older, probably above 60, yes, maybe like above 55, something like this. And what about like rheumatoid? Is it gonna be a bit different? Younger, yes. So like lower mid-age, kind of those kind of like ranges. So like maybe think 40s to 50s. This is when it starts to show up. Obviously, it's going to continue. It's a chronic disease. Also, pathophysiology is completely different. If we focus on osteoarthritis, let's start with osteoarthritis. What is the pathophysiology behind that? It's chronic mechanical stress, right? It's a wear and tear damage. No, not osteoclast. No, it's not osteoclast increase. Osteoarthritis is chronic mechanical stress. So that's why it's more with age, right? Because whenever we get older, like if you imagine the toll it takes on the joints as we move older, as like we move with time, it's gonna be like much more when you are like more and when you're like older, right? So it's friction. It's chronic friction and chronic stress that destroys the articular cartilage, and then it leads to this type of like inflammation. So it's inflammatory, but it's minimal inflammation. It's not like something that's autoimmune, such as rheumatoid arthritis, which is autoimmune, right? So pathophysiology here is autoimmune. It's mainly like inflammatory. And if I ask you specifically, what type of hypersensitivity reaction would we see in rheumatoid arthritis? Type 2. Okay, so a bunch of you guys are like saying type 2. We can see type 3 and type 2. Mainly we're going to see type 3, okay? Remember that. That's for rheumatoid arthritis. But mainly we're going to see type 3. Type 3 is for immunocomplex deposition, right? And for rheumatoid arthritis, this is like more inflammatory, more like if we take like an aspiration of the joint fluid, we're gonna see more cells, right? More inflammatory cells, right? If you do a synovial fluid analysis. So this one is gonna be probably less than the cutoff for like 2000, but this one is gonna be from 2000, let's say up to like less than 50. something like that. Because if we reach the 50 cutoffs, what are we thinking of? Like, I'll give you an example. Someone who has like a sudden inflammation, very red, one joint, one articular, and we have a bunch of neutrophils. It's neutrophil dominant and it's more than 50. Very good, you guys. This is going to be septic infectious arthritis. Nicely done, you guys. So now if we look at osteoarthritis, since we said pathophysiology is wear and tear and it's more with age. So most common risk factor is age. Another risk factor is what? Is it more common in males or females? What do you think? It's not common in females, do I know? Actually, it's more common in females. Yes, which is very sad for us because rheumatoid is also more common in females, right? So what else do you guys think? Imagine, like I told you, this is a wear and tear. So imagine someone who's thin and someone who's like BMI is high. Trauma, nicely done. Weight. So obesity and trauma. So any like sort of previous trauma, even if it was like not that hot, not like that bad, it's going to put you at an increased risk of developing osteoarthritis as you move on. So someone who probably like played a lot of sports, got injured a lot, maybe had like an ACL tear, maybe like underwent some kind of like arthroscopic surgery, he's at more risk. He is at more risk than someone who has like naive joint that did not like undergo any kind of trauma, right? That's completely different. So for rheumatoid, this is female, like we said. Do you guys know like what's the HALA association for rheumatoid? I'll give you guys a hint. It's DR what? Yes, very good. So it's DR4. Actually, it's DR4 and 1, but mainly like 4. And this one is also associated with what? DR4. Diabetes. Very good. Diabetes type what? Type 1, obviously, yeah. This is the one that's autoimmune. What about like Addison's as well? You can see it in Addison's as well. So, okay, what about the pain? Is there a distinction between the pain, between the two? Which one is like, at the morning is like more and stays for like more than an hour? Very good. So this is morning stiffness more than an hour. It used to be half an hour. There's like contradictions across resources, but we want to look at like more than an hour, maybe half an hour. Okay. And osteoarthritis is going to be less. Which one is worse at the end of the day? And which one like requires you? Yes, very good. So osteoarthritis is worse at the end of the day. Okay, what about symmetry? Which one is symmetrical? Which one is asymmetrical? So symmetrical is rheumatoid. Very good. So this is asymmetrical. That's in terms of joint involvement across left and right side of the body, as well as like the joint itself, the like the loss of joint space. It's also going to be like symmetrical and asymmetrical depending on the type of arthritis that you have, right? So sometimes for osteoarthritis, you're going to see like mainly medial loss of joint space. Because if you think about it, we're gonna like lean more medially when we're like putting our weight on our knees, because the most common joint that's affected is also gonna be the knee, and then we would also see like the hip joints. So joints, okay, now we're talking about joints. Tell me the joints most commonly affected in rheumatoid, and tell me the ones that are spared for rheumatoid arthritis. Okay, so this one spares the distal interpharyngeal. Very good, okay. And it's going to affect which ones? Commonly, which ones is it going to be affecting? Proximal, okay, and wrist joints, very good, and metacarpopharyngeals, nicely done. Okay, what about osteoarthritis then? For in terms of the hand, so this one is going to affect the distal, right? Very good. What else? What is the common joint that's affected? Knee, okay, yeah, we're talking about the hands now. Okay, you guys are correct. I'm not saying you're not correct, but what else in the hand is affected? Think about this joint. Carpometacarpal joint. So CMC, carpal metacarpal joint, the first one. Because like we said, this is a wear and tear. So if you think about it, this is the joint that we commonly use like throughout day-to-day activities, right? So CMC, carpal metacarpal joint, the first one for the thumb. Okay, imaging findings, what are we going to see? For rheumatoid, let's start with rheumatoid. Are we going to see osteophytes? Or are we not going to see osteophytes? Narrowing, okay, we said the narrowing. So Dumai is correct. Yes, we're not gonna see the narrowing. We're not gonna see the osteophytes. Osteophytes are more osteoarthritis. These are bony spurs, which is like because of the friction, what happens is that like that constant friction is gonna give us subchondral sclerosis, which is like kind of like the alternative of fibrosis on the bone. So like the bones are going to be so thick because of the friction that happens, and also we're getting those like osteophytes, those bony spurs, like excessive bony spurs at these sites. Okay, what about rheumatoid? So for rheumatoid, we're going to see something that's like parallel. Okay, Sarah went a further step. We're going to talk about these. Let's continue with the image and finding first. What are we going to see? We're going to see osteopenia. So bony erosions. You're going to see like the bones being eaten up on the sides, right? Because of the constant inflammation that's happening, it's going to eat up at the bony ends. We're going to look at all of these, you guys, when we do a bunch of questions as well. Okay, what else? So like extra specific things. So rheumatoid, like we said, rheumatoid is what? Rheumatoid is an autoimmune disease. So we are going to see extra articular manifestations. What kind of extra articular manifestations are we going to see? Felty syndrome, nicely done. Okay, so since you mentioned it, Suzai, what is Felty syndrome? It's a triad of what? Okay, neutropenia, splenomegaly. Very good. Yes, very good. Okay, let's go back. So what else is like extra specific to rheumatoid? We said it's autoimmune, extra articular manifestations. Let's think more kind of like general things that you see in autoimmune disease. So like fatigue, fever, like maybe like pancytopenias, those kind of things. Yes, anemia, very good, Carol. Yes. Those are the kind of manifestations that you're gonna see. What else are we gonna see for rheumatoid arthritis? What about what is like the autoantibodies associated with it? Can you tell me? Which one is like sensitive for rheumatoid? No, Sarah. Sensitive is rheumatoid factor. Very good. Rheumatoid factor. What else? Oh, so Suzanne is pulling up all of the high yield things, like the highly specific things. Very good. So specific is anti-cyclic citrullilated peptides. That's very specific. Sensitive is rheumatoid factor. And I'm gonna ask you a further question. Rheumatoid factor is an IgM that targets what? FC portion of what? Of IgG. Nicely done, you guys. FC portion is the constant region, because for immunoglobulins, we have like constant region, we have the variable region. Very good. And that's the specific one. For osteoarthritis, nothing kind of like is more specific. Here, we have nodes or nodules that happen because of those like bony spurs that happen. We have ones in the distal and we have ones in the proximal interpharyngeal joints. Very good. Which one is which? So Bouchard is where? P with P. So these are the Bouchard one. Proximal. Very good. Distal is going to be the Herpenden nodes. Okay, what about the deformities we're going to see for rheumatoid? Deformities, like joint deformities. I'm going to give you an example. So this is, like, look at where my hand is pointing. What is this called? Ulnar deviation. Very good. What about so someone mentioned swan. So in swan, what do we see? Swan and boutonnieres. What I would recommend is memorizing only one. So this is boutonnieres. Boutonnieres is hyperextension of the distal and flexion of the proximal. So swan is the opposite. Hyperextension of the proximal and flexion of the distal. That's swan neck deformity. So memorize one. In my opinion, this is the easier one than swan. Like if you try to imagine a swan neck, I would assume like this is harder. So this is boutonnieres. This is how it would look like. Hyperextension of distal, flexion of proximal. Okay? So these are the deformities that you're going to see. Treatment-wise, do you think treatment is different? What would we give? Yes. Okay. What's the treatment for rheumatoid? Okay, disease-modifying drugs. Very good. What are those? Which ones would you want to use? Methotrexate, nicely done, you guys. Yes, we will talk about all of these in a minute. Okay, and if I have acute, like in an acute flare right now, what would I give? Glucocorticoids. Yes, very good. You can give NSAIDs. You mainly like use glucocorticoids for an acute attack of rheumatoid arthritis. Yes, nicely done. What about osteoarthritis? Like if I tell you someone mild presentation, just beginning now, what do we start with? Very good. Someone mentioned exercise. So exercise and acetaminophen, that's what you would start with. Then you can move on to NSAIDs afterwards, or maybe like further kind of management if it doesn't like eventually it doesn't work out. So this is rheumatoid arthritis. Like we said, remember this is an autoimmune disease. More likely it's type 3. We can see some type 2 affection as well, but then like it's more likely like type 3. Joint involvements, it mainly likes the wrist joints, it likes the metacarpopharyngeal joints, and the proximal. Distal are spared. The IP are spared, okay? And it's going to be symmetrical involvement. In the joint space, symmetrical involvement bilaterally, left to right. And you're going to see synovial inflammation. Like you say, you can see here, these are the bone erosions. It eats the bone, which is completely the opposite for osteoarthritis, right? We have bony spurs. Here we have osteopenia, decreased bone density, and erosions as well on the sides. Like you're actually like eating the bone, this inflammation. The autoantibodies, like we said, anticyclic, suture-related peptides, and rheumatoid factor. Okay, let's try and solve a question. So we have a 72-year-old woman presents with knee pain that worsens at the end of the day. There's joint space narrowing, osteophytes, and subchondral sclerosis. So now we talked about this, right? This is osteoarthritis. And you can see what guided you to this question. Whenever you guys are solving a question, whether that's like a QBank question or an nbme question, always think about what are they trying to tell me and what are they trying to give me to eliminate other options. So the age, the specific thing is like the osteophytes, the subchondral sclerosis. All of these are very specific to osteoarthritis. Okay, nicely done. So it's a degenerative disease, weight bearing joints. So that's why like with obesity, it's more likely that you see osteoarthritis. Wear and tear, more common with aging, obesity, joint overuse, female sex, and prior joint trauma. So that's why athletes are also more at risk for osteoarthritis than people who don't really like do so many sports, right? Pain worsens with use, improves with rest, no extended morning stiffness, and we talked about the specific X-ray findings. Managed with activity modification, weight loss, exercises. So if I tell you I have someone who has knee osteoarthritis, which specific exercises would you recommend? Knee osteoarthritis. So no, not like, think about, yes, we want to strengthen the quadriceps. We want to kind of alleviate some of that like weight and like the amount of things that the joint is like trying to withstand, right? So you strengthen the quadriceps. Weight bearing exercise, we would recommend if we're trying to treat what? Something else, not a joint disease. Weight bearing exercises. Because someone mentioned it. Osteoporosis, nicely done. Okay, let's take a look. And like we said, we're going to give NSAIDs, but be aware about the side effects for NSAIDs. Okay, what about this one? We have a 47-year-old woman. Look at, she's a woman, and look at the age as well. Morning stiffness and swollen proximal, metacarpopharyngeal, and wrist joints. There's joint erosions. So which antibiotic is specific? So look at this. It's asking specific. So that's why it's anticyclic suture-related. This is where most people like make a lot of silly mistakes. Take a close look at what the question is asking and then answer, right? Because everyone's gonna be like, oh, rheumatoid factor, that's it. But no one is like looking at the question stem itself. So it's asking about specific. And this, like we said, sensitive. What about anticentromere? What is this one targeting? Crest syndrome, very good, which is limited scleroderma. Okay, what about anti-double-stranded DNA? What is that one for? SLE, nicely done. Is this one specific or sensitive? No, it's not sensitive, you guys. This is specific. Alongside with anti-double-stranded and anti-Smith, both of them are specific. Which one is sensitive for SLE? Very good, Anna. ANA is like kind of an overlap in most autoimmune diseases. You're gonna find that ANA is positive. Okay. What about if we're talking about SLE, that's like drug induced? Which antibodies are we gonna see? Antihistones. Nicely done, you guys. Okay, like we said, rheumatoid arthritis, autoimmune inflammation, more common in females, symmetrical, involvement, stiffness more than an hour, that improves with use. What are we going to see? We're going to see the pannus in the joint space. We're also going to see systemic inflammatory symptoms. Fever, weight loss, cytopenias, like all of those kind of manifestations. Positive rheumatoid factor, which is an IgM against the IgG, the FC portion of the IgG. Sensitive and the anticyclic citrullinated is more specific. Okay, we talked about all of these. This is the ulnar deviation. That's just a picture for the ulnar deviation. Okay, let's see this one. Now we're going to talk like a bit further about the management and the drugs that we can use. A 58-year-old woman with rheumatoid arthritis presents with painful mouth ulcers. She's been on rheumatoid arthritis medications for 6 months. There's neutropenia and anemia. What is the cause of her symptoms? Okay, why everyone is saying methotrexate. What is the mechanism of action of methotrexate? What does it inhibit? Very good. It's going to inhibit dihydrofolate reductase. Very good, you guys. So, and it's one of the side effects is mucositis, which is those like painful mouth ulcers, right? As well as it can cause bone marrow, like suppression. And someone mentioned folic acid. Nicely done. It's gonna cause folic acid deficiency. So if it causes folic acid issues, what type of anemia are we gonna see? Macrocytic, very good, or megaloblastic. And what's the rescue medication? Do we give folic acid? Leucovorin, which is what? Phenytoin can do the same kind of manifestations. Yes, very good. This is folinic acid. Very important because they will give both of them. They will include folic acid and folinic acid as well. So be aware. This is the one that we would use, and it's sometimes referred to as leucovorin rescue, right? What other side effects can I see for methotrexate? What other side effects? Hepatotoxicity. Nicely done. What else? Lungs. Yes. Fibrosis. Very good. So usually we will follow up with CBCs, PFTs, and LFTs, right? So like we said, this is it inhibits dihydrofolate reductase. Side effects are ulcers, bone marrow suppression, hepatotoxicity, pulmonary fibrosis. How do you prevent this and how do you treat it? With folinic acid, leucovorin rescue. What other drugs can we use? Tumor necrosis alpha inhibitors, second lines, which are infliximab and adalimumab, right? So these are monoclonal antibodies. There's another drug that works similarly to those by targeting TNF alpha, but it's not a monoclonal antibody. Do you guys know what it is? Intercept, very good, which is what? It's a decoy receptor, right? Yes, very good. Yeah, not very, it's very good. So, and when we do those, when we give those, so for this one, you wanna like do CBCs, LFTs, and PFTs, right? But if you're trying to give TNF inhibitors, you need to make sure there's no latent TB, right? So you test for latent TB. You do like a tuberculin test, maybe you do an EGRA assay, you do some kind of like test to rule out latent TB before you start the treatment. Why? Yes, very good, because it's going to stop the maintenance of granuloma. So reactivation of TB is going to happen, right? Because maintenance of granuloma is mediated using TNF. If you take this away, you're going to risk the reactivation of TB. Okay, let's do this question. A 60-year-old woman with long-standing rheumatoid arthritis is scheduled for surgery with intubation. What is the most important step pre-intubation? And why? Tell me why. Why are we doing this? Atlantoaxial instability. Nicely done, you guys. So we have this in rheumatoid arthritis. There's this risk. So before you do any type of intubation, because in intubation, you're going to hyperextend the neck, right? Yes, I was going to ask you, Susie. Nicely done. I was going to ask, where would we see this? We are going to see this also in Down syndrome. People in Down syndrome have the same laxity with their atlantoaxial joints, which is called subluxation. Yes, exactly. Which is not a true like dislocation. It's kind of like just laxity and instability of the joint. You test for it using a lateral cervical spine and you like fixate it. If it's there, you just fixate it using surgery. Someone mentioned Felty before, so this is Felty. When you have rheumatoid plus neutropenia and splenomegaly. And we also have, what else can we have? So in rheumatoid arthritis, you can have anemias due to the medication. You can also have anemia due to the disease itself, chronic anemia of like chronic disease, right? An anemia of chronic disease, it's usually going to be what type? Yes, normocytic, exactly. It can switch off into microcytic, but usually it's normocytic. What else are we going to see? High ferritin. Nicely done, you guys. Yes. Because why? Because we're trying to save up those like iron. We're trying to like maintain it in order to not allow like whatever it is that we think is happening to the body to kind of like take away our iron, right? We're trying to save our supply. Yes, and we're gonna see increased hepcidin. Yes, you guys are correct. Hepcidin is the mediator that that prevents like the release of iron from the macrophages and from the liver as well. So we can see many types of anemias in rheumatoid. Okay, be aware, like if they give you rheumatoid, is it because we're not appropriately treating this person and it's anemia of chronic disease, or is it because we are treating this person and it's a side effect due to methotrexate? Okay, so like you need to be very, very aware about that. Okay, that was rheumatoid and osteoarthritis. Now we want to talk about gout and pseudogout. Okay, want you to tell me the differences. In gout, what are the crystals that are gonna get deposited? Okay, very good. These are needle and these are rhomboid. But what are the names? Like, what are the contents? So these are what? Made up of what in gout? Very good. These are monosodium urate. Okay. What about pseudogout? Yes, calcium pyrophosphate. So it's called calcium pyrophosphate disease. Okay, what about, someone said something about the pyrofringes. So the pyrofringes, which one is positive, which one is negative? Let's start with like just positive and negative, then we're gonna talk about why. So gout is negative. And if it's negative, that means when it's parallel to the light source. Like if this is, let's imagine that this is like the light source. So, and the red one is the needle shaped crystal itself. So when it's parallel to the light source, it's gonna be yellow. And when it's perpendicular, it's gonna be blue, right? Very good. What about the pseudogout? So rhomboid, and they're positive or negative as well. Reverse, very good. So these are positive birefringes, which means when they're parallel to the light, they're actually blue, and when they're perpendicular to the light, they're gonna be yellow. Yes, very good. Okay, let's go back to risk factors. So gout, what are the risk factors? There's a ton of risk factors for gout. I'm expecting a bunch of answers. Very good. Alcohol, chronic kidney disease, like hyperuricemia. Maybe we have someone who uses high purine diets. Drugs, which drugs? Tumor lysis syndrome. Nicely done, you guys. Everyone is saying a bunch of options. Thiazides, you can see it with loop diuretics as well. So all of those kind of things. And if we have like overproducers, right? So it's usually either under excretions of uric acid or overproducing of uric acid, which we would see if we have like Lish-Nyhan syndrome, those kind of things, right? And combined mechanism, we would see it like in von Gork disease. Yes, nicely done. Okay, what about pseudogout? What's the risk factor there? That one is a bit like niche. Hemochromatosis, very good. What else? So no, it's not hypothyroidism. No, it's hyper. I think someone mentioned it. Yes, hyperparathyroidism. Just imagine that there's like an issue with the calcium. So that's why you would see this. Mainly hyperparathyroidism. Those are the main high-yield ones that you're going to see. So what about the joints? Most common joints affected for gout is what? Very good. Okay. Metatarsal pharyngeal joint, which is the first one, which is also called the podagra. Very good. What about the pseudogout, which is the commonest joints that's affected? Knee. Nicely done, you guys. What about imagings? What are we gonna see? Like that's more specific to it. For gout, let's start with gout. So tophi are found in soft tissues. They're not found inside of the joint space. No, not pannus. No, as well as not pannus. What we would see? We would see erosions with overhanging bones. That's the kind of thing that they like to mention, or like punched out erosions with like hanging bones or overhanging bones. Okay. And in pseudogout, what would we see? Chondrocalcinosis, very good. Which is what? What does it mean? What does that mean? Calcifications, yes. So you probably would see like a linear line of calcium deposits inside of the joint space. Yes, chondrocalcinosis. It's not like 100% specific, but these are like very specific to the presentations. Okay, what about treatment? Do you guys know treatment? How would we treat it? Let's start with gout. Acute management. You would start with NSAIDs? Very good. So would you start with NSAIDs or colchicine? You start with NSAIDs, then colchicine. Then what? Like, if I tell you someone who's like contraindicated to all of these, yes, then you move on to steroids. Very good. We'll talk about the chronic management in a bit, but let me ask you, what's chronic management? Okay, xanthine oxidase inhibitors, allopurinol, very good. Very good. Febuxostat. What else? What about things that increase its excretion? What about things that turn it into something that's like more water soluble? Yes, very good. So rasbicurase and also propincet. Very good, you guys. Well, what about pseudogout management? For acute. Acute, it's similar. But chronic management is different here. What's the chronic management? What do you guys think? Okay, that's good, David. Yes, you're probably gonna treat the underlying disease, but if you're like you're not able to treat the disease and it still happens, there's like recurrence attacks. What are you gonna give to prevent the recurrent attacks? You can give colchicine. Yes, Sarah, very good. You can give colchicine because it's an anti-immune drug, like it's gonna decrease the inflammation. Okay, and septic arthritis, we talked about this. Septic arthritis, yes, very good, Kushi. It's a microtubule stabilizer, yes. So let's talk about septic arthritis. What are we gonna see in septic arthritis? Presentation, very sudden, very acute, monoarticular usually. You're gonna see the aspiration of the joint fluid more than 50, turbid, very neutrophil dominant, swollen joint, fever, maybe systemic findings, all of those nice things, yes. What is the most common cause? Bacterial, which is Staph aureus. Very good. What about if I tell you someone who's like 30 years of age with a lot of like sexual behavior with unprotected. Yes, very good. Neisseria gonorrhea, very good. I think someone mentioned chlamydia or no one mentioned chlamydia. Can chlamydia give you septic arthritis? No. What is it gonna give you? Reactive arthritis, very good. We're going to be talking about reactive, which was called reiters, but nowadays we're not going to see reiters like the name. Okay, what about, so that's Neisseria gonorrhea. What about someone who has, who has sickle cell disease? Salmonella, very good. Is it the most common cause in that subgroup? Like if I give you someone who has sickle cell disease and now presenting with septic arthritis, it's not the most common cause. No, still Staph aureus. Still Staph aureus. Yes, very good, David. Still is going to be more common Staph aureus. But like just one that's very specific to sickle cell is Salmonella. So if they give you someone with sickle cell, you want to look at like, is it or is it not? So like you need to rule out specifically. If they give you both of them, you go with Staph because it's more common. Unless something else in the question stem is like hinting towards Salmonella. Okay. And how do we treat septic arthritis? Drainage, very good. So drainage. It's not just aspiration, like you do drainage under aseptic conditions, and then you give IV antibiotics. Okay, let's see this question. So sudden overnight pain, redness and swelling of the right big toe. He drinks alcohol regularly, needle-shaped, negative birefringence. So this is gout. Makes sense, right? So this is gonna be gout. Monosodium urate, like we said, triggers are a lot of things. Alcohol, red meat, cystitis, chronic kidney disease, and then we have the overproducers as well, with like tumor lysis syndrome and Leschny-Hand syndrome. What's the Enzyme that's deficient in Leishman syndrome. Very good, you guys. Okay. Okay, let's go back or let's check out, okay, swollen joints as well as the needle. Let's like take a picture. Let's look at the picture. So this is how it would look like. See, when this is the pole of light, when it's like horizontal to the pole of light, it's gonna be yellow. When it's parallel, it's gonna be yellow. When it's perpendicular, it's gonna be blue. And these are the tophi. Someone else mentioned the tophi. These are how the tophi are gonna look like. Okay, so a 50-year-old man with recurrent gout has an acute attack. Joint fluid confirms gout. What is the treatment of this acute episode? Okay. See how we're talking about the acute episode because this person with an acute attack, I can ask you this, like, I can ask you a different question. I'm just going to say, what are we going to give this patient to prevent future attacks? So you need to be very aware about what the question is. So now if I'm talking about like prevention, I'm going to pick allopurinol, right? If I'm talking about an acute attack, I'm going to pick NSAIDs. Unless there is like a risk factor or like a contraindication to NSAIDs. What's a contraindication that's going to let us move on to another medication? Maybe chronic, yes, ulcers, and then we move on to colchicine. What else can make you move on from colchicine? What's a contraindication there? Unless it's like very severe, no, Kushi, like allergy, okay. Severe renal failure, like renal failure, end-stage renal failure, alongside like liver disease and allergy as well. It's gonna make us move on from colchicine to steroids. And you can give steroids like systemically or injections as well. Okay, and can we give allopurinol during the acute attack? Can we give it? No, exactly why? What's gonna happen if we give it during the acute attack? Makes it worse. It's not just unnecessary. It's gonna make it worse, yes. It's gonna exacerbate the attack because why? Because it's gonna like remobilize the uric acid, so it's gonna make the like the episode much worse. What else can we avoid? We should avoid in an acute attack because it's also gonna make it worse. What do you guys think? Alcohol, obviously, yeah. Propensid, yes. Okay, yeah. All of these medications we want to avoid. Something else that's also an NSAID. You want to avoid aspirin in an acute attack. So you can give NSAIDs, but you don't give aspirin in an acute attack. Why? Because aspirin in low doses, it kind of fights with the excretion receptor on the kidneys. So that's like it fights with uric acid. Yes, it's going to reduce the excretion of uric acid because it's going to competitively fight with the receptor there, with the channel there. In high doses, it doesn't do that, but still, like, just avoid it in general. So you avoid aspirin, you avoid all of the medications that we give for prevention when we have an acute attack. Okay, let's take a look here. So like we said, NSAIDs, colchicine, which inhibits microtubule polymerization. So it's going to decrease the numbers of white blood cells. We have steroids as well. These are xanthine oxidase inhibitors. Like we said, these we can't use in an acute attack because it's going to make it much worse. This one inhibits reabsorption of uric acid, propensid. Pegloticase. So for rasbicurase, we like to use it for tumor lysis syndrome. For gout, we like to use this one, pegloticase. Okay, we much rather like use this one. They like to ask about what is the solute that's it's gonna turn into, which is allantoin, which is soluble, it's water soluble. So that's why the kidney is able to get rid of it like quite nicely. Okay, so this one has hemochromatosis, swollen knee, there's chondrocalcinosis, rhomboid, and positive birefringence. So this one is straightforward, right? This is pseudogout. Okay, so like we said, this is calcium pyrophosphate crystal deposits. We're gonna see it in hyperparathyroidism, hemochromatosis. We're gonna see the chondrocalcinosis. Acute management, same. Start with NSAIDs, move on to colchicine, and then steroids. Prophylaxis or prevention, you're gonna give colchicine. Okay, and this is how it would look like under the pole of like polarized light axis. Okay, what about this one? And I want to ask you a further question though, before we move on. Crystal arthropathy, so gout or pseudogout, what type of immune cells are we gonna see like dominating the synovial fluid? It's gonna be what, like predominantly? Neutrophils, very good. They like this question a lot as well. And it's not gonna reach the cutoff of 50, but it's gonna be much like more than what you would see in osteoarthritis. Osteoarthritis is the least one with inflammation. There's still inflammation, but it's the least one with the inflammation. Okay, so this one. Acute right knee pain, swelling, redness, fever, cloudy, purulent fluid. And for this 72-year-old man, what is the most likely cause? What is the most likely bacterial cause? Staph aureus, very good. We're gonna do joint aspiration and IV fluids, like drainage, full-on drainage. Okay, and it's gonna be purulent, white blood cells more than 50,000, and they're gonna be neutrophil predominant as well. So for gonococcal infections, it can present in two like ways. Either monoarthritis, like purulent monoarthritis, or a triad of skin infections, like skin lesions, polyarthritis, and tenosynovitis. But this is like more common, the purulent monoarthritis. Okay, let's talk about seronegative arthritis. First of all, what does that mean? So pair, everyone is saying pair. Nice. But what is it? What does that mean? What does this word mean? Very good. That means that rheumatoid factor is negative. And they like to commonly affect which types of of joints. It's also called seronegative spondyloarthritis, right? So it likes to affect vertebral and axial joints as well. Exactly. So what does the P stand for? Psoriatic arthritis. What about the A? Ankylosing spondylitis. Very good. What about the I? IPD related. So Crohn's or ulcerative colitis. What about R? R is reactive arthritis. Nicely done, you guys. Okay, so for psoriatic arthritis, we're gonna see psoriasis, right? So skin manifestations, like nail manifestations as well. So like pitting in the nail bed or stuff like that. And if we want to look at imaging, what are we going to see for psoriatic? Pencil cup appearance. Nicely done. Pencil in a cup deformity. That's what we would see. Ankylosing spondylitis. What are we going to see for this one? Affection of which joints specifically? Sarioiliac and the vertebral joints, so bamboo spine. If we have fusion of the vertebral bones, bamboo spines. Inusitis, very good. We're going to see this a lot. We're going to see it with all of them, seronegative arthritis. All of them, you're going to see like the inusitis and the tendinopathies and the tendinitis. All of these we're going to see it with them. Okay, what else can we see for ankylosing spondylitis? Anything that like affects the, let's say, the aorta? Eye manifestations, very good. Uveitis, very good. And in uveitis, what other thing can we see for the aorta? Aortic regurgitation, you guys. They have associations with aortic regurgitation. Very good. Respiratory manifestations, what would we see? Respiratory. Decreased thoracic mobility, very good. Limited chest wall expansion. So if we do a pattern, yes, it's going to be a restrictive pattern. If we check the Delco for the patient, is it going to be low or normal? Normal. Why is it normal? Why? It's not an intrinsic like parenchyma lung disease, right? The cells are fine. The issue is not being able to like move because we have costochondral joint involvement. So we have stiffness there, not being able to expand the chest wall. So the issue is outside of the lung. It's extrinsic. So that's why Delco is going to be normal. Where else would we see this? Also like intrinsic pattern, restrictive disease, and obesity. So obesity, hypoventilation syndrome. And what type of like HALA positivity would we see for all of these people for seronegative arthritis? B27. Very good. Okay, let's go back. So ankylosing spondylitis. Talked about the aortic manifestations, the respiratory manifestations, all of those kind of things. Usually, is it a male or a female? Male. Very good. Usually younger in age, and it's better with movement as well. So it gets better with movement. The stiffness and the pain in the joints, it gets better with movement. Okay, and IPD, honestly, nothing that high yield about it, except it's gonna happen in the setting of IPD. So yeah, someone who has like Crohn's disease or ulcerative colitis now having some kind of like arthritis and issues with the joints. What about R, reactive? Where would we see this? Reactive arthritis. following what kind of infections? Chlamydia infections. Nicely done. What else? Campylobacter. So these are the two commonest ones. So GI, GU. You can see it in Yersinia. We can see it in Shigella as well. All of those kind of manifestations. And what's the triad for reactive arthritis? Can't pee, can't see, can't climb a tree, right? Or can't bend my knee. Yes, very good. So urethritis, and what's the eye manifestation? Is it uveitis as well, or is it something else? Conjunctivitis, yes, very good. It's conjunctivitis, it's not uveitis. And if we want to compare like conjunctivitis versus uveitis, first of all, conjunctivitis, the redness, you're going to see it in like the white spaces, right? Mainly. For uveitis, you're going to see it like around the iris, mainly. It can like bleed into all of like the white spaces. But the most important distinction is the eye, like the vision manifestations. With conjunctivitis, you are less likely to see any affection of the vision itself. Uveitis, you can see like vision affection, blurry vision, those kind of manifestations. Climb-patry, obviously, that's the arthritis. Okay, let's take a look. So we have someone who has chronic low back pain, worse in the morning, improves with activity. He's a man, 35. Occasional red, painful eyes, limited spinal flexion, and X-ray shows sacroiliac fusions. Very good. So this is B27. Those people, do you think they benefit from like methotrexate, for instance? People who have ankylosing spondylitis. No, they don't usually benefit from it. What do we give them? First line is NSAIDs, very good. And they kind of respond very well to NSAIDs. If you want to give something else, what do you give? Exercise, yes, very good. What else? You can give infliximab. Yes, very good. So TNF inhibitors, they respond very well to it. Like they respond very, very well to it, but they don't respond to methotrexate. They also respond very poorly to steroids as well. Okay, so like we said, improves with exercise. We have the uveitis, the aortic regurgitation, and the restrictive lung disease that's extrinsic. So the delta is going to be normal. If you check the labs, you're going to see increased inflammatory markers and HALA-B 27 positive. This is the bamboo spine, the fusion. Okay, and this is kind of like the manifestation, sacroiliitis and bamboo fusion as well. Okay, what about this one? Arthritis, conjunctivitis, and dysuria 2 weeks after a bout of bloody diarrhea. And what's the most likely organism that gave him this diarrhea? Campylobacter, very good. And this is reactive arthritis. Someone mentioned the old name. The old name is Reuters, if you ever see it like in a textbook. So it can follow chlamydia, campylobacter. These are the most important ones. It can follow Yersinia, Shigella, and Salmonella as well. And that's the classical triad. What you would give for them, yeah, is support. I'm not highlighting as much like treatment-wise, except for things that are very relevant to step 1. That's why. Okay, can't see, can't pee, and can't climb a tree. Okay, and this is, let's do this one, and then we'll move on to like a few questions from the question bank. A 27-year-old woman presents with a malar rash, photosensitivity, oral ulcers, and RBC casts. Okay, this is SLE. Remember the antibodies we talked about for SLE? So SLE is also an autoimmune disease. More sensitive for it is ANA. Specific is anti-double-stranded and anti-Smith. Manifestations, if you see arthritis, it's going to be symmetrical as well. It almost looks identical to rheumatoid arthritis. But with rheumatoid, it's more likely that you see arthritis in general than it is with SLE. You are going to see extra-articular manifestations as well, like pericarditis, psoriasis, like all of those manifestations, you're going to see them. Let's take a look. So you are going to see pericarditis, pleuritis, you're going to see oral ulcers, photosensitivity, and the rash. It's very specific that it spares the nasolabial folds. These are the nasolabial folds. Okay? Okay, if I give you someone who has SLE, is pregnant, just delivered the baby, what is the most common complication, most likely complication for the baby? Heart block, yes, very good. Bradycardia. What is the antibody that this patient is going to test positive for? Very good. This is a key piece of information, like anti-SSA, which is actually anti-Sjogren syndrome A or Rho. This is positive in Sjogren syndrome, but If you have it positive in someone who has SLE, they're more likely to develop neonatal lupus, which presents with heart block and bradycardia. Okay, let's do a few questions here. Let's practice these kind of questions. Okay, first off, you always want to read the final end of the question. Which of the following imaging findings most likely going to be seen? So now we know we just want to reach the diagnosis to look at the imaging finding. 66-year-old woman comes to the physician because of a 9 month history of progressive right knee pain. She describes the pain as deep ache that's most severe after she spends the afternoon walking or grocery shopping. The pain is typically relieved by sitting down or resting in bed. She notes that her knee feels locked and stiff for approximately 15 to 20 minutes every morning upon waking up. There's hypertension, BMI is 33. Physical exam, there's no detectable warmth, edema, or significant diffusion. Palpable grating is felt during passive flexion and extension of the joint. Examination of the hands show hard, non-tender bone enlargement over the distal interpharyngeal joints. And vitals are fine. So which of the following imaging finding? What's the diagnosis? And tell me what led you to this diagnosis out of the hints inside of the question step. It is osteoarthritis, very good. So, okay. Obese, age, distal. Okay, very good, you guys. Yes. Features of the pain, specifically what we would see like it. Also, like the grating, the less detectable warmth and inflammation that you would see. Very good, yes. And it's gonna be, are you sure you guys wanna pick A? Asymmetrical joint space narrowing and subchondral sclerosis. Okay, very good, yes. You guys would be correct. What is B? Marginal erosions and symmetrical joint space narrowing. What's B? Very good. What is C? Linear calcium deposition within the articular cartilage. Calcium deposition. Pseudogout. Very good. What is D? Punched out erosions with overhanging edges. Gout. Yes, very good. What is E? Diffuse increased bone density with obliteration of the medullary cavity. What is this one? Osteopetrosis. Very good. What's the pathophysiology of osteopetrosis? It's not Pagets, Sarah. So with Pagets, they would probably mention some kind of imbalance between osteoclast and osteoblast overactivity because it goes through phases. Osteopetrosis, what's the pathophysiology? They would mention mosaic pattern for Baggett's disease as well. Osteoclasts are not working. Yes, very good. And it's not an intrinsic issue within the osteoclasts themselves. The osteoclasts, they need this enzyme to provide an acidic environment for them to function and do their job properly. So we have the carbonic anhydrase, specifically type 2, that's deficient. So now the osteoclasts are not able to function. If they ever mention the obliteration of the medullary cavity, they're probably talking about bone marrow is going to be gone. So that's kind of what differentiates Pagets disease from osteopetrosis, because we're going to have thickness in both of them. But if you are trying to highlight bone marrow is gone, pancytopenia, you want to think osteopetrosis. But Pagets is more common, okay? Remember, Pagets is more common. And these are the manifestations. See, these are the bony spurs you're going to see at the ends. For rheumatoid, the ends are going to be gone. They're going to be erosed, eaten up, and there's bites of bones on the ends. And the subchondral sclerosis, see how it's excessively wide in the edges because of the constant friction of the bone. And the joint space narrowing is not that it's not symmetrical. Inside of the joint itself, it's not even symmetrical. Okay, so bony stiffness, morning stiffness, crepitus, and these are I was gonna ask you about this, guys. So these bone enlargements in the DIP, what are those? DIP, bone enlargements, what are those? Bony spurs, which are, we talked about these nodules. So are they Bouchards or Herpendine? Yes, very good, yes. Like I said, P with P, so Bouchard is proximal. And it's a chronic degenerative joint disease by progressive destruction of articular cartilage due to mechanical stress. What do you lose? You lose type 2 collagen and protoglycans, leading to thinning of the cartilage and exposure of the underlying bone. Unlike the other inflammatory arthritis, it's not systemic, so you're not going to see the fever, you're not going to see the weight loss, you're not going to see this like systemic manifestations, right? That you would see with rheumatoid. You can even see it with like seronegative arthritis. You're not going to see those, like the fatigue, the fever, the non-specific manifestations. Okay, so like we said, marginal erosions. Let's see this one. So marginal erosions, you can see the edges of the bones are kind of eaten up. So that's the erosions. Those are rheumatoid arthritis. Linear calcium depositions, let's take a look. Yes, this is how it would look like. You can see some kind of depositions and excessive whitenings inside of the joint space itself. Punched out erosions and overhanging edges, this is gout. And it's mainly going to affect the podagra. Diffuse increased bone density with obliteration of the medullary cavity, this is osteopetrosis, like we said. This is just like comparison between them. Okay, let's see the next question. So which of the following mechanisms best explains the chronic joint inflammation and destruction observed in this patient? 55-year-old woman presents with a 6-month history of symmetrical pain and swelling in her hands and feet. She reports severe morning stiffness lasting more than an hour, which improves with activity, okay? There is worn, tender, swollen MCPs, metacarpopharyngeal, and PIPs, joints bilaterally. Elevated erythrocyte segmentation rate, so it's an inflammatory condition. CRP is also high. Positive anti-citrullinated protein antibodies. We did the x-rays. There's periarticular osteopenia and marginal joint erosions. So what is this one? So I'm seeing a lot of these, yes. And what is the diagnosis? Rheumatoid arthritis. Very good. So like I said, this is mainly going to be immunocomplex deposition. This is type 3, mainly. You're going to see some type 2 manifestations. If I ask you, let's look at SLE. So SLE, lupus is mainly type 3 as well, right? But sometimes they like to ask about something in lupus. They like to ask about the specific manifestations in lupus that's mainly not type 3. Nephritic is also type 3. But in lupus, what would we see that is type 2 hypersensitivity reaction? Very good. So cytopenias like anemias, thrombocytopenias, those kind of manifestations, leukopenias, are mainly type 2 in the setting of SLE. Cytopenias, yes. And if I ask you even more, what is the type of like autoimmune hemolytic anemia that we see in SLE? Is it warm or cold? Very good. It's warm, yes. What do we see? Do we see IgE or IgM? IgG. Very good. IgM, you would see it in cold, which is more mycoplasma. Very good, Hardik, yes. Okay, so like we said, this is mainly type 3. There's like a cascade that happens with the pathophysiology of rheumatoid arthritis. Like you have a lot of like citrin-related proteins, so that's why the autoantibodies is targeting those. But it's not as high yield to like understand the specific pathophysiology. Honestly, it's not understood to like a full extent. But you're gonna see a lot of pro-inflammatory cytokines like I'm sorry, not inhibitors, interleukin-1, interleukin-6, and proteases, cholinestrases, all of those kind of things. Okay, and direct autoantibodies, no, that's type 2. And like we said, while this can have some kind of participation, it's not the main like type hypersensitivity reaction that you would see. CD8 plus, no, as well. And IgE mediated, that's type 1 hypersensitivity. And granuloma, this is a subtype of chronic inflammation, right? Okay, let's see next question. Which of the following pathophysiological process is responsible for this condition? A 66-year-old woman comes to the physician because of a 3-year history of bilateral knee pain and stiffness in her fingers. She reports that the pain is more severe in the late afternoon and evening, particularly after she has spent the day gardening. She notes that her joints feel tight when she first wakes up, but the sensation resolves within 15 minutes. There's bony enlargements and mild tenderness of the distal interpharyngeal joints of both hands, palpable crepitus during passive flexion and extension of the right knee. There's no associated joint warmth, redness, or ulnar deviation. Okay. So they gave you a lot of things to kind of like eliminate rheumatoid, right? So we're thinking osteoarthritis. And the answer is going to be what? It is mechanical, yes. But like I said, there is some sort of like, you're going to like irritate the system, right? So we are going to have increased activity of the degradative enzymes, right? they're gonna eat away at the joints. But it's not gonna be autoimmune mediated. And deposition of monosodium urate, this is gout, right? Inflammation of the tendon insertions, where would we see this? For D, where would we see D? Ankylosing spondylitis. You can see it in all seronegative arthritis, but mainly ankylosing spondylitis. Proliferation of synovial tissue into a vascular panels. This is also going to be rheumatoid. Yes. Okay, let's see this one. Which of the following best describes the mechanism of action of this drug? So she's 45, 6 months history of persistent pain and swelling in the hands and wrists. She reports that the symptoms are most severe when she first wakes up, often lasting for nearly 2 hours before improving gradually as she begins her daily activities. No significant medical history, no medications other than ibuprofen. There's symmetrical swelling, tenderness of the second and third metacarpopharyngeal joints and proximal interpharyngeal joints. Boggy sensation on the dorsal aspects of both wrists, so wrist affection as well. Vitals are fine, right? There's elevated ESR, CRP. The patient is diagnosed with an inflammatory condition and on a first-line disease-modifying agent. Okay, everyone is picking C. C is what? This is the mechanism of action of which drug? Methotrexate, very good. What about like A? What's A? Binding and neutralizing of tumor necrosis factor, infliximab, very good. What about binding to intracellular receptors and inhibition of NF-κB mediated transcriptions? These are steroids, very good. What about inhibition of dihydroorotate dehydrogenase? Do you guys know? So this is not as high yield, but for dihydroorotate dehydrogenase, this is leflunomide. Okay, that's the mechanism of action of it. We don't necessarily use it unless there is like some very high contraindication for methotrexate. So it's not asked about, like they don't really ask about it that much. And isoinoside, isoion monophosphate dehydrogenase is the mycophenolate mofil. Okay, that's the mechanism of action of it. Okay, so these are the drugs that you would use. These are the commonest ones that you would use. You want to remember the mechanism of actions for them specifically. Like if you want to just memorize the first one, that would be like amazing. They like to ask about TNF inhibitors because these, they have the reactivation for TB. So like they have a very specific like side effect, right? I would say they like to ask about sulfasalazine as well because they would give it to you in the sense of someone has a sulfa allergy. So you want to avoid it. So the question is going to be someone who had like some kind of allergic reaction to TMP, SMX, or like some kind of antibiotic in the past. And now we want to give him a medication. Which one should we avoid? So we want to avoid like this one. That's the setting how it's usually asked. Okay, let's do this question. So it's asking about an organism, okay? The organism that's most likely the cause of this patient's condition. He's a boy, 8-year-old boy. 2-day history of worsening right knee pain, high fever. The knee is so painful he refuses to walk. He has a history of multiple hospitalization for severe pain in his arms and legs that were treated with intravenous fluids and oxygen. He also had an episode of painful swelling of his hands and feet when he was 10 months old. On examination, his temperature is 38, so it's high, blood pressure is fine, pulse is also for his age fine, respirations. There's notable scleral ectras. The right knee is warm, erythematous, and exquisitely tender to palpation with a significant effusion. Range of motion is severely limited by pain. We did the analysis, or like we did lab studies. So hemoglobin is low, hematocrit is low, reticulocyte count is low as well. Leukocyte count is very high. We did the synovial fluid analysis, 90,000, and neutrophils are predominant, 92%. We did the stain gram-negative bacilli. Okay, which one would you pick? So I'm seeing a lot of like D's and C's. It's gonna be salmonella. Why? Because they gave us the stain, gram-negative stain bacilli, right? If they didn't give us the stain, or they mentioned in the stain gram-positive, cocci, now you want to think about staph, right? But since they mentioned specifically gram-negative bacilli, so this means that this is salmonella, right? If I'm testing you about someone who has like Neisseria, I'm thinking about Neisseria. If I tell you that the gram stain is negative, does that rule out like Neisseria infection? So gram stain is negative. No, it doesn't rule it out. Why? Why doesn't it rule it out? It could be negative. Very good. So it's not sensitive as well as that Neisseria is also like sometimes intracellular. So it can just be intracellular. That's why we didn't call it. And the gram stain is not that's like sensitive to detect it. We would usually use NAT to diagnose it. Like we said, salmonella, and they didn't straight up told you that this person has sickle cell disease. Like you had to deduce, like, right, so that this person has sickle cell disease because of the previous history, the kind of like history of acute attacks, and you also like have the hemoglobin to help you out. Okay, let's see this question. So the medication most likely used to treat this patient's acute symptoms primarily acts by which of the following mechanisms? So 62 came in because of a 12-hour history of severe pain and swelling in the left great toe. The pain began suddenly during the night and has become so intense that he cannot tolerate the weight of a bed sheet on his feet. Significant for hypertension, treated with hydrochlorothiazide, and a recent hospitalization for a bleeding peptic ulcer. Vital signs are fine. The left first metatarsobpharyngeal joint is racematus, warm and exquisitely tender to palpation. With it, arthrocentesis and the synovial fluid is obtained for analysis. Okay, 38,000. Neutrophils predominant. Crystals are needle-shaped and negative birefringence. So everyone is saying C. Why C? So this is colchicine. Yes, very good. But why did we skip NSAIDs? Because of the bleeding ulcer. Very good. So now that's why we moved on. If there was no history of bleeding ulcer, we would have went with which one? Very good. A, because A is for NSAID, inhibition of prostaglandin synthesis. Promotion of renal urate excretion. What is this one? Very good. Yes. What about inhibition of phospholipase A2? It's propensid. It's not allopurinol. No. Inhibition of phospholipase A2. This is steroids. Very good. Lowering urate production. What is this one? Very good. This is allopurinol. Okay. So we skipped it. This is how you would go. You use NSAIDs, you move on to colchicine, you move on to glucocorticosteroids. Okay. Okay, let's see the final question. Which of the following factors most likely aggravated this patient's condition? 65-year-old man presents to the emergency department with 12 hours of severe pain in the right forefoot that began abruptly overnight. He denies trauma. He's unable to bear weight. He has chronic systolic heart failure and was discharged from the hospital 5 days ago. Uh, After treatment for volume overload and at discharge, the dose of one of his medications was increased. His reports attending a family celebration 3 days ago where he had one beer with dinner. Current medications are lisinopril, metoprolol, and furosemide. Vital signs are fine. Examination shows a single swollen erythematous warm, exquisitely tender joint at the base of the right big toe with markedly decreased range of motions due to pain. Reminder of musculoskeletal examination is fine. With it, arthrocentesis, needle shape, negative birefringence. So everyone is saying, so I'm seeing a bunch of like different answers, right? So C and D. So which one do you guys want me to pick, C or D? So we all know that this is gout. We just want to know what caused like this acute attack. So you guys want me to pick C. It's not C. Why is it not C? So recent alcohol intake. Let's look at his intake. 3 days ago, one beer. This is not enough for this to like increase the risk of an attack. If it was yesterday and more than 2 beers for a male, that's when you would like assume, okay, now this probably it increases the risk. So, and if you take a look at the previous like history, he was discharged 5 days ago after being treated for heart failure with volume overload. So we probably increased the dose of which medication? Out of all of these three medications, which one did we increase? Furosemide, very good. So loop diuretics. So that's why. So recent medication dose is the one that kind of like triggered this acute attack for gout, right? So always be very careful about what they mention and what they don't mention. Because we all know that alcohol is a trigger. This is not the issue. The issue is the amount of alcohol. And when did he drink this? He drank this like 3 days ago. This is not gonna put him at risk for an increase, like a risk for an attack. But yes, remember to compare them. So negative, birefringence, positive for calcium pyrophosphate. and the risk factors as well. Okay, that's it for this session, you guys. Honestly, amazing performance from everyone. You guys like have been amazing. You participated in almost all of the questions. Thank you so much for joining this session, and keep the same stamina throughout all of your prep, and I hope everyone gets the pass and the score that they're looking for. Very good. Thank you so much. Thank you, everyone. It was nice meeting you all.